Good morning, everyone, and it's a pleasure to be here and to speak on the CNS infection, pediatric CNS infection. Oh. Yep. And I have nothing, no declaration, no financial interest or relationship. In this half an hour, what I am going to do is to give a basic of pediatric CNS infection that we see. And as you know, the prevalence is very high in the developing country, and the causative organisms vary from geographical areas. But mostly they present with seizure, fever, and sepsis, and neurological deficit. Imaging is mainly centered around CT and MR. And in MR, mostly the conventional imaging been done, but special sequences like DWI, ADC mapping, SWI, spectroscopy and magnetic transfer helps in differentiating different kind of infection that you see. And in recently higher field, shorter sequences and better resolution been applied also. So let's see, the causes could be varied from virus, bacteria, tuberculous, fungus, and parasites. Let's start with the question one. Here is a patient, 4-year-old child, or a fourth ventricular lesion, central hypodense on T2 image, irregularly enhancing area, that's the FLAIR image, and that's the spectroscopy. Now, if I just help you out in giving the differential diagnosis, this fourth ventricular lesion could be either a medulloblastoma, ependymoma, hemangioblastoma, epidermoid, and tuberculoma. And if I discuss this, anybody can go for diagnosis here. Yeah. Okay. All right. So let me do this exercise. In medulloblastoma, as you see, the age is very important, and a typical medulloblastoma can have this kind of a bizarre appearance, bizarre kind of a cystic solid areas, and on contrast, they can have this kind of an enhancement. But when you do a diffusion, there is a very light diffusion, very small areas of diffusion restriction seen, and ADC high. And when you do a spectro, there is almost no NNA, and there can be slight lactic peak that you can see. So therefore, on perfusion, you see there is a perfusion in this lesion. Therefore, I think the medulloblastoma will be out from the differential diagnosis. Let me help in this. Ependymoma, as you know, a little older age group. You see typically a lesion which goes into the orifices or the foramina lusca or the mesendi, and you can have some kind of a bizarre kind of a enhancement that you may sometimes see. On diffusion, you can see slight restriction in small areas of restriction, and on on perfusion, you see a larger area of perfusion that you see. So this particular lesion doesn't seem to be falling in this particular category, so I'm ruling out the ependymoma. Hemangioblastoma is slightly older age group, around 20s, and you see a lot of flowoids, and the enhancement pattern can be of solid and cystic, large rim lesions and a lesion. And I don't think this is an hemangioblastoma. Epidermoid is one of the common differential diagnoses, follows the CSF signal intensity. On diffusion is very, very bright. So therefore, this lesion, particular lesion, seems to be an epidermoid. So therefore, you cannot just make a diagnosis by exclusion. Let's see how prospectively we can do it. This is the lesion, the same lesion, which is irregularly enhancing. On diffusion, there is no restriction. And on spectroscopy, what you see is a large lipid peak. This is T30 and 135. So what we have this database is that a central T2 hypodensity, non-significant central enhancing solid component, variably thick enhancing wall, no perilysin edema, no diffusion restriction, and very high lipid resonance. Therefore, this diagnosis should be a tuberculoma. Now, I'm not going to ask for the diagnosis, but remember these images that I'm going to show you. And I'll ask this question again at the end of my talk. T2 the T1 contrast and FLAIR images. Identify the cystic ring enhancing lesion, tuberculoma, neurocysticercosis, cryptococcus, hydatid cyst, or pyogenic abscess. Remember the diagnosis, and I'll come back again at the end of my talk. Another question that I'm putting up, look at these lesions, see T2 based image, and then the contrast enhancing, contrast MR. Now here the question is, what metabolic alteration would stand out in the proton MR spectroscopy of these patients? Elevated choline, succinate, amino acid, creatinine, lipid. And the last question here in this series is that this is a contrast enhanced MR. And what do you feel? Is a normal enhancement, leptomeningeal carcinomatosis, pyogenic meningitis, subarachnoid bleed, or tubercular meningitis? I'll come back again to all these questions after I take the next of the thing. So CNS tuberculosis, as you know, is 1 to 5% of all tubercular patients. They present as a form of meningitis or as a parenchymal lesion like cerebritis, tuberculoma, abscess. Complication in the form of infarction, hydrocephalus is very common. Tubercular meningitis is very high mortality and morbidity in children and adolescents. There is a rupture of the wrist focus leading to thick enhancing gelatinous exudate in the basal ganglia, basal cistern, then spread to the convexity. FLAIR is somehow more sensitive than T2 weighted image. Hydrocephalus is very common sequelae, and as we saw, as we have been seen, that very low MTR is seen in tubercular meningitis than in pyogenic and fungal. Here is an example of a tubercular meningitis with gross hydrocephalus. Here is the basal exudate, enhancing basal exudate that you see prepontine as well as in the other areas. And one of the differential diagnosis when you see this kind of a meningeal enhancement is a leptomeningeal metastasis, where you have a typical molten wax appearance that you can see. Tuberculoma can occur hematogenous or direct. It can be parenchymal or extraaxial origin. In children, mostly it's infratentorial. Corticomedullary junction or periventricular region is most commonly involved, and in 10% of cases it can be associated with meningitis. In tuberculoma, there is less edema. Post-GAD, either you get a ring-enhancing lesion or a nodular lesion. In diffusion weighted image, you see an hyperintense center. MR spectroscopy, you see a very large lipid peak. And MT improves the detectability of this lesion. There are 3 pathological varieties of tuberculoma that one sees: non-cageating granuloma, granuloma with solid cageation, and granuloma with central liquefaction cageation. Here is an example how they look like on T1, T2 and enhancement. Non-cageating granuloma will be seen as hypo, hyper with nodular and homogeneous enhancement. Whereas tuberculoma with solid cageation will show as hypo or iso, T2 hypo, and a rim enhancement. Whereas in liquid cageation, it will be hypo with central hyperdensity on T2 and hypointense rim with a rim enhancement. Let's see some of these examples. This is a kind of a nodular enhancement, solid, non-cageating granuloma, T2 hypo, ring enhancing lesion. This is solid cageation with tuberculoma, and T2 central hyperintensity with hypointense rim with ring enhancement you can see in liquid cageation. Here is an example, isointense area, enhancing, on FLAIR it is hypo. This is an example of a tuberculoma non-cageate or solid cageation. Another example of a solid cageation, it is T2 hypo. In liquid cageation, there will be a hyperdense center with the peripheral rim which is hypointense, as seen in this example. Sometime in 10% of cases you may see associated meningitis, again a tuberculoma with a solid cageation, T2 hypo, and associated with a meningeal enhancement that you see here and there, with a ring enhancement that you see. You see a very large lipid peak in the tubercular lesion from the center, whether this is a cageating or a non-cageating. Other form of CNS tuberculosis could be in an abscess formation when it's very rare, very larger in size, enhancing lesion and a very low MTR. In HIV, when it occurs with tuberculosis, there will be mode of meningeal enhancement and tuberculoma with infarction. In children, as a complication, they involve the middle cerebral artery. There can be neuropathy, patchy meningitis, or encephalopathy. Here you can see an example of tubercular meningitis with diffusion restriction in 2 different areas with infarction. And another tubercular meningitis, solid meningeal enhancement that you can see. This is the area which is T2 hypo. So this is an area which is probably will form in a tuberculoma with solid caseation. And this has a large, this is a diffusion weighted image showing a very large area of diffusion restriction leading to an infarction. Miliary CNS tuberculosis can also be seen in the form of a nodular enhancement. And as we see that magnetization transfer, if somebody does it, will thickened meninges appear hyperintense relative to surrounding brain parenchyma in basal and supratentorial cistern. And empty ratio from this thickened meninges of tubercular meningitis is significantly lower than that of pyogenic or fungal infection. There is a consensus statement that has been derived in childhood tuberculosis, where the neuroimaging is a very important tool. And one of the important factors that is derived in this that normal CT scan doesn't rule out a tubercular meningitis. Coming to the next common infection that we encountered is a neurocysticercosis. And this is the commonest presentation with a solid, with a ring enhancing lesion with a scolex formation with edema. It's a major cause of epilepsy and neurological disease in many developing countries. And because of the increased globalization, this is spreading across the world. As you all know, the human is the definitive host in NCC, and it can be either a parenchymal lesion, intraventricular, or a racemose type. In parenchymal, it can be either vesicular, colloid vesicular, granular nodular, or nodular calcified. How they look like, excuse me. If I take the vesicular lesion, will be thin cyst wall, CSF-like density, eccentrically placed scolex with no enhancement and edema. In colloid vesicular stage, there will be thick, turbid, high signal intensity on T2. Scolex may not be visible at this stage. The enhancement will be marked and the edema will be marked. There is a consensus guidelines how to diagnose and treat neurocysticercosis, and it has been very clear that an absolute criteria for diagnosing cysticercosis is a cystic lesion with a scolex that is seen on CT and MR. Of course, there are major criteria like suggestive of neurocysticercosis when after therapy with albendazole or they show resolution, or there can be a spontaneous resolution of this lesion. In our country, most of the cysticercus presents as solitary cysticercus granuloma, and even in this case, there are CT and MR feature which are very suggestive of cysticercosis, a small ring lesion less than 2 centimeters in size with fluid content will be most likely a solitary cystic granuloma. And as has been shown that treatment whether with the antihelminthics or steroid will have a similar kind of a response in these patients. This is what is a classical vesicular stage with the scolex, colloid vesicular stage with edema and the scolex that can be seen. Of course, you can see many stages in the same picture. This is what is the rim becomes more thicker in granular nodular stage, and in calcific stage, which is dark on T2, you can see better on CT than on MR. Interventricular cyst, you can see in fourth ventricle with a scolex in eccentrically placed scolex, but in racemose type, which is multiple cystic lesion, you don't even see the scolex. Here is an example of another racemose cyst on CT, on MR. And as you know that the evidence of scolex on imaging is absolute criteria for diagnosing the NCC, but the racemose variety and many of the interventricular cysticercus may not show the scolex itself. And there is a need for doing a high resolution 3D T2 weighted MR images either in the form of Cyst or Fiesta or SPACE, which helps in detecting the scolex. But as you remember, scolex can be seen on any sequences like on T1 image, on T2, on T1, on FLAIR, on FLAIR images. Here is a cyst which is done on a supine MR, a cyst in the fourth ventricle which moves on prone position. So cyst within a cyst appearance can be seen in cysticercus cyst. So cyst within a cyst appearance can be seen in ventricular system, and frequently it is caused by the cysticercus cellulose. Bladder and bladder appearance also is reported in the literature, but it's very rarely seen. And the outer cyst is probably because of the sequelae of the ependymomitis. Inner cyst is actually the cysticercus cyst. Here is an example of a occipital patient with a occipital seizure. And on this image, what we see is the two cysts that is there. On FLAIR, one of the cysts is suppressing, another is still hyperintense on FLAIR image. And on treatment, following treatment, there is a complete resolution of this hyperintense area, hyperintense cyst. This is a subarachnoid form of NCC, which is multiloculated and do not exhibit any scolex. One of the larger study which has shown that these patients may not need an antihelminthic all the time because of the, and though it is indicated that they should get with a single lesion or a multiple lesion, many children with isolated neurocysticercosis will improve without anti-parasitic therapy. Disseminated neurocysticercosis is typically seen as a starry sky appearance, which can be seen either on CT or an MR. Moving from here to hydatid cyst, as you know, the human being is an intermediate host in the HYDATID, and the intracranial HYDATID is caused by the Echinococcus granulosa, seen in 1 to 2% of all patients with hydatosis. Typically, these lesions are solitary cystic lesion, supratentorial location, non-enhancing cyst wall, no significant perilesional edema, and the cyst calcification is very, very rare. When you take a spectroscopy, you typically see a succinate peak in this. This is a class. As you see in other extracranial cerebral hydatosis, there will be atypical picture also in HYDATID in the brain. One can see a honeycomb appearances, one can see water lily sign, and wall enhancement or calcification can also be seen in HYDATID cyst. As you see the hepatic HYDATID, the adapted cerebral HYDATID can have a similar kind of a classification. The CE1 is like unilocular cyst with no daughter cyst. CE2 is unilocular cyst with a discernible wall and daughter cyst. CE3 is multiple cyst, honeycombing kind of a pattern. And C3, 4, and 5 could be either water lily sign and calcified HYDATID. Let me see some of the examples. This is a typical CE1 active lesion, no discernible wall you can see. With daughter cyst in the periphery you can see in CE2. With multiple honeycombing like a cystic appearance that you can see in CE3. These are transitional stages. CE1 and 2 are the active phase. And this is typical water lily sign wall enhancement that you can see in HYDATID even. This is CE4. And another one that you can see is a floating membrane sign that been described in liver HYDATID, also can be seen in the cerebral HYDATID. This is also CE4. And you can see the wall calcification in an HYDATID which is supracellular in location in this particular patient in the CE5. So similar kind of HYDATID cyst can be seen even in intracranially with a similar classification, adapted classification. So from here we move to bacterial infection. As you know, in bacterial infection, the microorganisms vary with the age, the mode, and the immunity. And most of the time the imaging is required for, not for the diagnosis of pyogenic meningitis, but for the complication of the bacterial meningitis in the form of either an abscess or infarct. So early in the imaging, in a very early bacterial infection, the imaging may be normal. The exudata is typically iso on T1 and hyper on T2. On FLAIR imaging, it's hyperintense in the sulci and cistern it is seen. Diffusion weighted images is abnormal whenever there is a vascular complication, and contrast these exudates enhances. Here is an example of a complicated kind of a bacterial meningitis. You can see this early cerebritis formation here. There is a subdural kind of an enhancement that you can see across the area. So the complication could be in the form of hydrocephalus, vascular complication, cerebritis, abscess formation, subdural collection or epidural collection is a differential diagnosis of empyema. The imaging is mainly hyperintense to CSF, enhancing membrane you can see in subdural empyema. Underlying brain is showing ischemia or abscess formation. MRB may show dural sinus thrombosis, and epidural it may be hypo with hypoline on thing. So this is an example of a subdural empyema that is seen on the MR. Here you can see this very classic irregular type of enhancement in the subdural area with underlying brain which is showing an ischemic or cerebritis in the underlying brain. So one of the differential diagnoses will be could it be just a subdural effusion or hematoma, which is not difficult in differentiating on MR imaging with contrast. An abscess formation is most common in the frontal and the parietal lobe, and imaging varies with the pathological stages, whether it is an early cerebritis or a late cerebritis, early capsule formation or a late capsule formation. As you see here, the sine qua non of a pyogenic abscess is a smooth ring enhancement, and that's differentiated from the metastasis, which is usually multiple and the rim is very, very irregular. One of the major factors in the pyogenic meningitis is the diffusion restriction that you see. Very bright diffusion restriction that you see in the center part of the lesion, which can also be seen in tubercular abscess or a tuberculoma with liquid caseation. You can see similar kind of a diffusion restriction in the center. And when you take the spectroscopy, you will see typically the lactate, the succinate peak in the tubercular, in the pyogenic meningitis, pyogenic abscess formation. This is an example of a cerebritis that you can see enhancing with capsule formation, early capsule formation. When it is intraorbital, then there is an involvement of the cavernous sinuses, which has a very bad sequelae in such patient. It can be complicated with CVT, as is seen here is the empty delta sign. The bacterial abscesses can also be complicated with the daughter abscess, ventriculitis, choroid plexitis, and purulent leptomeningitis. Here is an example of two daughter abscess with choroid plexitis that is seen. And you see the diffusion restriction in the center part of this. This is a purulent leptomeningitis that can be complicated with pyogenic meningitis. So when you deal with a pyogenic meningitis, pyogenic abscess versus tubercular abscess versus fungal abscess, the way to differentiate is that when you see the rim, it's smooth on both pyogenic and tubercular, but in fungal it is a crenated with intracavitary projection. In diffusion it will show restriction in both the cases, whereas in fungal abscess you will see the restriction in the periphery, in the wall of the lesion. On MRS you see acetate lactate and succinate peak in pyogenic abscess, lipid peak in tubercular abscess, and amino acid lipid peak in fungal abscess. Let's see some of the example here. Here is a pyogenic abscess, very smooth central diffusion restriction, and you see lactate and amino acid and acetate peak. This is a tubercular kind of an abscess where you see a very large lipid peak. And in fungal abscess, you see the lactate and amino acids peaks over there. So moving here to fungal infection, usually the common infection that happen in the immunocompromised is Aspergillus candida, whereas both in immunocompetent and compromised patient you can see Cryptococcus or Coccidiomacosis or Histoplasmosis. The pathophysiologically yeast is showing is common like Cryptococcus. They have a gillette, they have either in the form of granuloma or abscess formation. The hype is involved the parenchyma rather than meninges in Aspergillus or mucor. In pseudohype, it is the candida that both parenchyma and meningeal involvement can be there. So here is an example, is a sinus involvement, brain involvement, and there is a typical enhancement that you can see, nodular enhancement that you can see in the meninges in Cryptococcus. Primarily the basal meningitis, there can be Cryptococcus, there can be gelatinous pseudocyst, which is isointense to CSF on T2, hyper on T1. This is a classic distribution of Cryptococcus that you can see, basal ganglia involvement and enhancing in the form of nodular enhancement. And this enhancement can be seen in the nodular form of a meningeal enhancement that you can see in cryptococcal meningitis. Aspergillus, it can be direct extension, iatrogenic, or hematogenous. It can have an infarct or hemorrhages. Here is an example, the T1 hypo, T2 hyper, ring enhancing lesion. When you do a diffusion, that's what I was speaking, it's the wall which is showing the diffusion restriction and in the form of a crenation that you will see in fungal abscess. In mucor also, usually the clinical setting is of that of diabetes, and one of the paranasal infection spreads into the brain in the form of a large enhancement in the cavernous sinus area as well as in the suprasellar region. Just let me show you two examples of fungal abscess, how they look like. Here is the T1 image, T2 center bright, peripherally dark cream, enhancing multiple lesion. On SWI, you see this magnetic susceptibility artifacts because of the iron or manganese deposit and the IP itself. And that's the diffusion which is restricted in the periphery. Another example, similar SWI abnormality or susceptibility artifact that you see in SWI, and on diffusion you see the peripheral restriction. Another example of a SWI, how nicely they pick up the susceptibility artifact. So the question that I asked is, what is the most likely diagnosis in this particular patient which has multiple lesion, with one of the lesions is showing edema? Let's find out what is the correct diagnosis here. I don't think there will be any doubt about the diagnosis. Everyone will make 100%. Yes. Can I have the results, please? Okay. Oh, surely. Another, this is the Fiesta or the images where you can detect the scolex very nicely in a T2, heavily T2 weighted images. And this is the spectrum of the neurocystic that you can see. Okay, next question was correct diagnosis. Next question was, this is the case that I have shown, and I have asked which metabolite alteration will stand out in the proton MRS of this particular patient: choline, succinate amino acids, creatine and lipid. Let's have the answer on this one. Okay. Yes, of course, it's the lipid peak that you will see in tubercular lesion. And that's the kind of lipid peak that you will see in tubercular lesion. Okay, what is this? I saw the case of young child with this kind of an enhancement, whether this is a normal enhancement, I don't know, this got wrong. It's a normal enhancement or enhancement, leptomeningeal carcinomatosis, or pyogenic, tubercular, or a fungal. May I have the answer, please, here? I've already shown it. Anyway, it's a cyst tubercular meningitis, more of a basal predominance. Okay, 100%, right. So here is another question that I have not shown you, is a typical MR picture that you see involvement of the temporal lobe, diffusion restriction. My question here is, which organism typically involves the area shown in this particular brain? HSB1, CMB, Japanese B, rabies, or varicella? Yes. Oh, 100%. Oh, still there is some doubt. I thought everybody will make a diagnosis of HSP1. Since my time is very limited, I'll show you typically one example of a rare disease that sometimes one can see is Japanese encephalitis. Many of you may not have seen many of the Japanese encephalitis. It's a typically involvement of the basal ganglia along with the cerebral peduncle and this substantia nigra, which is a very typical feature. And in endemic zone and a particular season of the year, this diagnosis can be established. And of course, the serological test is very important in making a diagnosis. This is one of our rare case that we have seen is a gross basal ganglia involvement, swollen basal ganglia, which is seen in a rabies kind of encephalopathy. And this I want to show a amoebic encephalitis patients. We saw in the last 5 years, 5 or 6 amoebic encephalitis. We couldn't make a diagnosis in any of them. And only very recently we could make a diagnosis. The pattern is more of like a multiple hyperintense lesion that is seen in the distributed, non-specifically in the brain. And along with that, you will see this gyriform kind of an enhancement in this is one of the autopsy patients which has an amoebic Naegleria amoebic encephalitis. I'm not going, the diagnosis here is HSP1. So in summary, there is a pattern recognition helps in viral infection. And in focal lesions, whether you see Aspergillus, then diagnosis is very simple. Lipid peak on MR spectroscopy. Central cavitary diffusion restriction is seen in bacterial and tubercular abscesses. But when you see a subperipheral diffusion restriction is a more of fungal granuloma. And the take-home message here is that you detect early, because these infections are very notorious, very high morbidity and mortality that you are associated with this infection. Try to diagnose everything on imaging, exploit the full MR and your knowledge to the fullest to give a correct diagnosis of the kind of organism that you are dealing with. Corroborate with the bacteriologist or virologist for the identification of the causative organism. Confirm or rule out. This is one of the most important job, the complications for optimal patient management, and do interval imaging for follow-up. Thank you for your kind attention, sir.